Please log in Dr. Tejinder. I think he's waiting. Can you somebody let him in the meeting?
Oh, ma'am, sir, we have given the customized link for sir also, ma'am. So he can directly join as a panelist itself.
I don't know. He said that he's waiting in the room. Just can you check with him, please?
Yes, ma'am. Yes, ma'am.
Yeah,
Yes.
thank you. Welcome, Tejinder. Thank you for joining.
You want me to start?
We'll wait for, it's not yet 6. We'll wait for 5 minutes.
Done, done.
Madangi, ma'am, could we start with the session?
Yeah, we'll wait for a couple of minutes. I think we'll see. Has everybody joined? What about the next session? They are aware that they have to join.
Yes, ma'am. Calls has given to all the faculty again to join. They will be joining in the week.
Okay. Just wait for 2-3 minutes and then we can start. All right?
Oh, okay, ma'am. Sure.
Yeah. Mm. I think we can start. If
Uma, you want me to upload the thing or?
I will just check. Roshni, are you there?
Yes, ma'am. Could we start,
Yeah.
ma'am?
Yeah, I think we can start. And is Dr. Tejendra going to upload the slides, or are we uploading the
I'll
slides?
upload. I'll upload from my side.
Okay, okay. Just tell me that.
I had sent it to her. But
Okay.
Okay, sir.
So we'll start.
Okay, ma'am. So, a very good evening, everyone. On behalf of International Association for Integrated Oncology, IAIO, I warmly I warmly welcome you to IAIO Expert Insights on Gynecological Cancer. I'm Joshia from IAIO and I'll be your compare for today's session. At the outset, I would like to sincerely thank our Program Director, Dr. Uma Dangi Ma'am, Senior Consultant Medical Oncology from Mumbai, for her academic leadership and guidance in curating today's scientific program. I now invite Dr. Uma Dangi Ma'am to deliver the welcome address and set the context for the session. Ma'am, over to you, please.
Thank you very much. So, good evening and welcome you all to this talk, to these expert insights in gynecological cancers. And as we know that gynecological cancers are an important cause of significant morbidity and mortality in women across the world. And over the last few years, we have seen a lot of rapid evolution evolution in the treatment of gynecological cancers. This has been basically because we've understood the disease better with advances in molecular biology. We know there have been some changes in screening strategies, surgical techniques, systemic therapies, and now of course we are in the era of personalized medicine. So definitely there has been a path forward, and there have been improvements in the outcome of gynecological cancer. And this uh, program today is mainly aimed to focus on these recent advances, as well as to try and see how we can actually implement them in our day-to-day practice. So without further ado, I'll welcome all our expert faculty and panelists who have joined today for this program. Over to you.
yeah, thank you, Uma. I think I'll start with the first topic, which is looking at personalizing treatment in endometrial cancer. What we are going to expect in 2026. 2026 is just now few days left now. Our now personalization in endometrial cancer has come both in the early stage also and the metastatic. We are seeing new medicines coming in every place, but the most important personalization has happened in the early uterine cancer. Day by day, we are moving away from the standard staging to risk stratification, which we are going to discuss today. We'll just give a brief and then we'll see what we are going to expect in 2023. So I think the important thing is that now we stratify the endometrial cancer not on the kind of stage what they are, but mostly by the molecular stratification. So we have patients who are pole mutant, those who are microsatellite stable, unstable, looking at the P53 and something known as NSMP. So this is now a classical thing which all of us know. And in the last few months, I think there are so many meetings looking at this population. How do we classify? So we have now 4 classical mutations, molecular markers. Remember one thing, that apart from endometrial cancer, no other cancer has got so much importance like what we see in endometrial, where molecular profiling has become the standard norm. Our first is a pole mutation. Whether the pole mutation is there or not, if any patient has got a pole mutation, it is supposed to be good prognosis. Then you have prognosis related with the P53. P53 mutation present means it's a bad prognosis. And it signifies that most of the patients are having high grade. Patients who are having DMMR basically are often bad prognosis per se, high grade. And here also the probability of getting a LVSI substantial is still there. The fourth category is known as no specific molecular profile. They are the one where there is a notable absence of TILs. ER/PR is diffusely positive, mostly low grade. Most of these patients are also high BMI. Only patients who are pole, basically, they do happen in a early onset and lower BMI. Remember why we are looking at this molecular profiling. We look at this molecular profiling mainly for the prognosis part. Patients who are pole, they are supposed to be good. Patients who are DMMR, they are supposed to be having intermediate prognosis. NSMP, which is no non-specific, no specific molecular profile, also belongs to basically they are the people who are P53 wild type and not having a DMMR. And P53 is the one which is basically a marker for poor prognosis. But sometimes when all the tests are done, the P4 mutation overrides everything. Now, coming to the pattern, I think this is a very common pattern which we tend to see in every patient, and we should do in early is endometrial cancer. Is we should first see the patient is having a pole mutation or not. And if it is not, there is no pole mutation, we should look for the DMMR. And those patients who are not DMMR, naturally they are PMMR. And then the next investigation should go with the P53, whether they are mutant or wild type. Those which are P53 wild type, mostly it is NSFP. This is a pattern which we tend to follow in our clinical practice. Another thing is the expression of LCAM. I think this is a one marker which is also most frequent in the P53, but is also signifies that the patient is going to have a worst outcome. And so many centers, they don't do the L1 cam, and some centers are still doing it, but overall the number of centers which are doing the L1 cam is also very less, including the pole also. Pole requires a special testing. Now, NCCN is very clear that how we should proceed. The previous chart which I showed is almost similar to this. First thing should be done is a pole. If pole comes negative, look and do the because the pole mutation is based on the hotspot, and this hotspots day by day number of mutations are increasing. And like previously, I remember only 2 to 3, but now they are around 8 to 10. So hotspot mutations are increasing. If the patient doesn't have a hotspot mutation, our next goal should be to do the IHC testing for MMR. Any patient who is having any kind of loss of expression will go to MSI-H or deficient MMR. Those patients who are basically MMR, we will do the P53 testing. And there, if it is wild type and if it is a mutant, mutant is supposed to be more bad, and wild type is known as NSMP. Now, NCCN has been now very clear about certain things, but more than the NCCN, the one which has really taken up this kind of testing is the ESMO. ESMO has been more clear. NCCN does tell about any patient who has been diagnosed as endometrial cancer. You should say whether he belonging to the high grade or low grade. But NCCN is not serious about it. Remember one thing, the certain histologies like clear cell, serous, carcinosarcomas are not been put up into this molecular testing, and these are mainly for the pure endometrioid adenocarcinoma. So and that's the reason why the ESMO is slightly different as compared to NCCN blocks, which we tend to see. The purpose of molecular testing is to really find out whether we can add chemotherapy based on a very well-known trial called POTEC trial, whether to remove the part of even giving the radiation also, and whether to add vaginal brachytherapy, whether we can add external beam radiation. But the main purpose is to whether to see whether we can add chemotherapy or not. So systemic therapy basically is decided based on this molecular testing, based on the risk stratification. This is another chart for similar to the patient that ideally we do tend to say that primary surgery is very important, but those who are not suitable, I think we should consider the role of hormone therapy. Now, another chart looking at the cervical involvement. Cervical involvement, whether to give radiation or not, is an important thing. Now this is important. Now, day by day, what is happening is that when we see patient of endometrial cancer early stage, uh, apart from the pole P53 and the DMMR, the histology is very important in the sense that we need to be very clear whether the neuroendocrine carcinoma is there, carcinosarcoma is there, or serous is there. Per se, any patient who is serous, carcinosarcoma, neuroendocrine, um, uh, uh, carcinosarcoma and serous, they will always be high grade, even clear cell also. Neuroendocrine has got a different treatment, which is not part of it. But doing a molecular testing for ER/PR is advised per se, and we should do it for mainly not for the stage 1 and 2, mainly for the stage 3 and 4 patient, and mainly for the recurrent cases. HER2 testing is also coming as a reflex testing, but remember one thing, how much utility it has got in the adjuvant, not there at all. Most commonly, the doing a HER2 testing should be totally for the recurrent disease or metastatic disease. But any patient who is having a clear cell histology, who's having a P53 mutant tumor, I think this is one area where HER2 becomes very important. So HER2 signifies a very similar outcomes, in endometrial cancer, similar like what we tend to see in the breast cancer. So HER2 testing is very important here. And HER2 testing, which we do in a case of endometrial cancer, we don't follow the breast cancer testing, we follow the gastric cancer protocol. We are looking at the basolateral pattern staining, not the circumferential staining. So HER2 testing is very important, but the type of testing is different as compared to what we do for the breast cancer. Now, this is a important chart, which basically I have taken it from the Pan Asian guideline, a very important guideline, because in the endometrial cancer nowadays, we see in our clinic and we try to like why precision oncology has come up here is one of the reason is this. And one of the trial which laid the foundation was a POTEC. So we divide them into very clearly low risk and intermediate risk and high risk. Intermediate risk is further divided into high risk, high intermediate, and normal intermediate risk. But the important thing here to see is the pole. Now, any patient who is having a per se stage 1A, which is grade 1 and 2 with endometrioid type, that is, even if they are deficient, remember the DMMR also is intermediate prognosis. And we see different kinds of LVSI. We see focal LVSI or substantial LVSI. Substantial means more than 4 group of LVSI which we see. So low risk is any stage 1A, grade 1 and 2 with endometrioid, including DMMR. We are not talking about P53 here because P53, any histology, all stages of P53 will directly go into high risk. So, but if pole is also part of the picture, pole overrides everything. Like I'm also very clear. The Pan Asian has told even if a patient is stage 3, pole mutation, you can put them into the low risk. Intermediate risk is something which is like stage 1A, G3, similar to what we see in the low risk, only thing the grade has improved. And any patient who is non-endometrioid stage 1A, like, we put it like carcinosarcoma, undifferentiated, clear, serous, they all go into intermediate risk. And also, but without any metal invasion or focal LVSI. High intermediate is stage 1 to 2, depending upon the type of whether mostly or most of them are DMMR. So DMMR will go into it. And high risk is any stage, any all histology with P53, abnormal time myometal invasion. But if suppose the early stage is there and the patient has got a pole mutation, it will override it. So pole mutation in any form with any abnormality will ultimately rule over there. Now coming to the question of any carcinosarcoma, serous one, all stages of carcinosarcoma will go into it. Stage 3, stage 4 with no residual disease, regardless of histology, regardless of molecular type, we should think about looking at giving chemo and the radiation to it. Now, let me just go with the stage wise, how we interpret our way of looking at the thing. Normally, stage 1 cancer, they get operated. The standard surgery, most of us know. But if the patient final histology is stage 1 and grade 1 and 2, and naturally premenopausal, we go ahead with the overall ovarian preservation. But if it is stage 1 grade 3, normally most of the centers, they do go for the sentinel lymph node surgery. And if it is a serous, naturally it is the surgery is equivalent to doing what we do for the ovary. So in a naturally in a Lynch syndrome, BRCA positive, remember any patient who comes out to be deficient MMR, we should see whether they are Lynch syndrome or not. So this is the NCCN again looking at the fertility preservation. I will not go too much into it, but when you discuss about the adjuvant therapy, we are very clear. You define the risk, like what we saw just a few slides back, that the low risk is you don't recommend adjuvant endocrine therapy, and patients who are basically stage 1 and 2 pole mutation, we don't recommend any kind of adjuvant therapy. Intermediate, there are 4 different lines which they have put it. It is not always that P53 in every form should be given an adjuvant therapy. Like, patients who are stage 1A and who are P53 and no myometrial invasion, but unrestricted to a polyp. Sometimes the polyp also can present. The adjuvant therapy is not recommended. But any patient who is like, stage 2 G1, even though they are deficient MMR, which is supposed to be intermediate, better to consider for at least a adjuvant VBT. But if the patient is less than 60 years, you can avoid going for the adjuvant brachytherapy. Stage 1B, G1, G2, basically adjuvant brachytherapy is recommended, and similar protocol like less than 60, you can omit the brachytherapy, and to the similar one, the grade 1, stage 1 and grade 3. So patient who are stage 1A non-endometrioid type and P53 without any myometrial invasion, the standard protocol is very clear that we don't go ahead with the adjuvant treatment. So that is what I'm telling you, P53 is not always a protocol. And second important thing is, even if it is stage 2 and a patient has got a pole mutation positive, and then also the patient is a low risk and we can avoid giving chemotherapy. Now, these are the 2 high intermediate risk. You have after node sampling and without node staging. So this is just a ESMO. Like I said, ESMO is very clear as compared to the NCCN. NCCN has still not incorporated all the molecular testing into place. Maybe in the next few years, they might come into the area. But any patient who is high intermediate risk, and the patients are who are stage 2, grade 2, grade 3, or grade 1 with substantial LVSI, a normal recommendation is to go ahead with the EBRT. But as a high intermediate risk, we do give them concurrent or sequential chemotherapy to EBRT. Like I normally give them 4 cycles of Paclitaxel carbo followed by radiation. But you need to have a substantial LVSI in a presence of grade 1 disease, and any patient who is grade 2, grade 3 and DMMR should also go ahead with it. Now coming to high risk, I think is like I said, all histology with P53 doesn't come into place because there was some confusion here. But any patient who is having serous, undifferentiated, including carcinosarcoma with myometrial invasion will go into it. Any patient with stage 3, stage 4, even though there is a small paper which is written that patients who are stage 3 pole mutation we can avoid, but somehow ESMO itself is saying that we have to think about giving them chemo plus also radiation. So this is what we used to follow about when we used to say which patient we need to give vaginal radiation, which patient we will give the external beam radiation, because the consideration is that any patient who is low grade, like grade 1, grade 2, we should give importance to the age. If the age is less than 60 years, you can avoid vaginal brachytherapy. If it is more than 60 years, you have to think about it. But day by day, I think we are more concentrating on the LVSI. The NCCN is not very clear with what doesn't mean by LVSI. ESMO has been very clear about the substantial LVSI and focal LVSI. So this point need to be very careful for every student. Basically, we need to see whether it is substantial LVSI or focal, which NCCN is not very clear. This is the stage 2 patient. NCCN talks about looking at the grade and giving accordingly. And stage 3, stage 4, they are also very clear because they also follow the OTEC trial protocols. This is something called inadequately stage. And so ideally, like I said, the protocol doesn't change so much here also in this staging. Carcinosarcomas are totally different. We don't tend to, there was a time when people used to say we should look at what is a carcinoma component or what is a sarcoma component. I think these diseases per se, they require both chemotherapy and radiation. That's the reason why molecular profiling will not go into this area. So these are some of the sequential and types of chemotherapy. The most common is basically your paclitaxel carboplatin. But is there any role of, category 1 relation to an adjuvant therapy? Whether is there any role of dostarlimab and whether there is a role of pembrolizumab? That is the one which we are now day by day debating and trying to see whether it will come into the place. And also the role of HER2 also. So NCCN do talk about it, but many centers we don't follow this therapy of giving pembrolizumab in the stage 3, stage 4 patient. But recommendation has come for the preferred regimen that you should think about adding it. Now, what happens to the loco-regional diseases? Whether we need to, I think rule is very clear. Those patients who have taken radiation previously, and the goal is to go ahead with the debulking surgery. Those who have not taken radiation, you should think about the role of radiation. Systemic therapy is a one area which is optional. That's the reason if you see the ESMO has been put up in a dotted finger, systemic therapy has not found to have any substantial role, or right now there is no thing. Now, I think metastatic is precision very important, because ultimately right now in a metastatic setting, I feel very important for every student to remember is that we don't do pole mutation and P53. Only thing which we do is the DMMR, HER2. And apart from these two testing, there are other markers we can think about doing is anti-RK based. But the two important molecular testing which is done is MSI, and the other is the HER2. So, and also the ERPR. So there are some patients who are having a low volume indolent disease. We can think about adding progestin and tamoxifen or fulvestrant. Those patients who are having metastatic disease, based on the molecular test, I think the MSI is very important, because there are two drugs which are there. One is a Dostar, another is Pembro. And now new drug which is now in the pipeline is based on the DOE trial, is the role of durvalumab with chemotherapy, where those patients who are MSI negative, MSS, basically olaparib was given as a maintenance. Like I said, options have improved. Those patients who are microsatellite stable, DOE says that you give the durva plus chemo followed by olaparib, whereas pembro data is also very strong based on the pembro and nilmetinib in those patients who are MSS. But yes, the two markers which are excellent to think about is the MSI and the HER2. So this is what the NCCN talks about the systemic therapy. I think NCCN, if you see, you have a category 1 recommendation for using Dostar, and the standard arm for everything is Paclicarbo. Same thing, if a patient is HER2 positive, then you can go ahead with the Paclicarbo and trastuzumab. The probability of HER2 positivity will be more with the carcinosarcoma and serous, and this is the area where we should get their testing done. What about the role of TMB? I think the only drug which has really got an approval based on the TMB high is the Pembro. And so biomarker directed therapies are very clearly, the role of IO is very prominent. There is a recommendation for using a lenvatinib in the proficient group also with the pembrolizumab. And then there is a long list of chemotherapy which can be used. You have hormone therapy, you have newer drugs like TDXT, which has got a tumor agnostic approval also. Very rarely I have seen this anti-RK gene fusion, which are less than 1%, but there are drugs which are available, larotrectinib and entrectinib, which can be thought about given. But the prominent thing which is there in endometrial cancer is now the role of immunotherapy and the anti-HER2 therapy, including a ADC called trastuzumab. Now, very important is, I think, which we have been using is a role of ER/PR testing. We are not so much bothered about the PR, we are more bothered about the ER. But in ER positive tumors, there is a phase 2 data for letrozole and CDK4/6 inhibitors also. Otherwise, we have been using the uh, migestrol with tamoxifen alternating. There is also very good data for everolimus and letrozole without any, but this patient need to be ER positive and not so much with the ER negative. So letrozole everolimus is a very important uh, overall therapy. The probability of response to this therapy, even in a third line, is coming to around 30 to 35%. Phase 2 data, very nice about ribo plus letrozole and abima with letrozole. The probability of response is coming in the tune of around 20 to 25 patients. So, so when we talk about uh, endometrial cancer, I think this is the only disease where uh, personalized therapy has come up in early stage. Like I said, pole mutation overrides other mutation in early stage, but the stage 3, stage 4 patients are still going the same way what we do. The thing which has happened in the stage 1 and 2 is the molecular testing, which has made us think more whether we can avoid chemotherapy, whether we can avoid radiation, whether we can avoid even the external beam and go only for vaginal radiation. So we have two types of endometrial, type 1, type 2, we know, but the type 2 is bad. We clear cell, undifferentiated serous, uterine. These are the population which has got a HER2 positivity. And uterine sarcoma, normally per se, disease-wise, stage-wise, we follow the same like endometrial cancer. The only problem is that the responses to molecular therapy is not there, and we are not very strict in doing it. Pole mutation, but DMMR and HER2 is very important in the uterine sarcoma. So, like I said, pole mutation is good, and whenever it is there, even if there's a presence of T53, it signifies good thing. TP53 has got the worst prognosis. So finally, low risk, only observation, intermediate risk based on the high and intermediate. Intermediate is only vaginal brachytherapy, high intermediate, which are defined based on the substantial LVSI, and patient who have where nodes are not addressed. We can think about adding, chemotherapy plus EBRT, especially if it is grade 3. And high risk, like I said, stage 3, stage 4 is the chemotherapy. So I think the personalized therapy has overtaken everything in the treatment of ovarian cancer. So, and what is the future in 2026? I think most important, I feel that not much is going to change. We already have the drugs which are already there, and we just need to, use them properly. Number of cases are not so high. Uterine cancer comes much below our ovary and cervical cancer. It's not, numbers are not so high, but yes, we have started doing mutation testing, and we are now far better than what we were previously. So I think this is the last slide. Nothing from my side. Thank you. Thank you, everyone. So over to you, Uma. I think any.
Thank you, Tejinder, for a very good talk. So, I think we are in an era where molecular testing is almost universal now, and more so we can see that it's coming earlier and earlier in cancer. A few years ago, we used to only do it in metastatic disease where patients had exhausted all therapy. But now it's coming more and more in the forefront, and personalization of treatment is taking even in the adjuvant setting. So I think there's slight delay in the next presentation, so we can have the questions till then. Any questions?
So somebody had asked here, what is the cutoff for ER positivity? So problem is that there is a here, we do say that 10% is the right answer. But remember one thing, endometrial cancer is not like breast cancer. Only in a low grade cancer, there's a use of giving anti-hormone therapy. If it is a high grade patients, high grade cancers, and the patient is ER positive, the probability of the probability of responding to anti-hormone therapy is less. I think these points need to be very clarified that we do talk about doing a ER testing for every patient, but in a high grade, how much they are going to respond is a big question mark. In low grade, agree. But yes, 10% people do talk about. This is an area where I think even in a breast, no one will say that if you have a 3%, you should not give it. But low grade indolent disease, there is a usage of giving anti-hormone therapy. High grade disease, ER positive, not much beneficial.
So Tejinder, Dr. Bishwas here.
Yeah, Dr. Bishwas, bolo.
So if you have a HER2 3+ now, are newly diagnosed, but MSI high grade disease. So what will be your first line treatment?
So the question comes here is that when you have both the things positive, what you're telling is patient has got a DMMR and patient has got a HER2. So, there is a recent data for adding both. There's a recent data to add anti-HER2 and Pembro both. Yeah, there was a previously question mark comes used to do it. You first give importance to HER2, then you give importance to the MSI immunotherapy. But I think recently it is very clear because those patients who are HER2, they are not going to respond to only immunotherapy. Immunotherapy is not going to work. So I feel that, I said there is data for adding both the things.
So I have a patient who is ER positive, PR positive, HER2 3+, MSI high. And this patient was started on chemotherapy by some of my colleague. So she did not respond to that.
Yeah.
And then this patient being a HER2 3+, she responded and she went into a complete CR with immunotherapy. So
Yes.
we have not exposed this patient to anti-HER2 because by the time I saw she was on 3 cycles, we did a scan. She had a torrential bleed. We gave an hemostatic RT. Now she continues to be in remission with pembrolizumab.
Yeah, so Ghanshyam, I think the only area where patient who are HER2 positive and deficient, where adding these two drug combination is where without even DMMR, which is there is in cervix, we have a substantial data of adding both the things. But like I said, adding both the patients, I will say that here I will be more happy in in a MSI high patients first giving immuno than going for trastuzumab, but very difficult to predict. There are some patients who never
Yeah,
respond.
the same thing is coming up in the BTCs, no? So if you have
Yeah.
a HER2 3+, then would you add? So we have already started adding durvalumab
Stomach also. Stomach, you just see, we are now adding both HER2 and Pembro. There was an initial concept of first giving a trastuzumab. If they fail, then go for Pembro. But now the data is very clearly talking. I think the biggest problem, which I am very clear, is that HER2 testing, the way we do that testing for HER2 is different. We need to understand every pathologist needs to understand that we need to do it. HER2 testing is this different. The gastric testing we employ for our patients who are having endometrial cancer also.
Right. Thank you.
I spoke less or I spoke more?
You spoke perfect. No, I think we're just waiting because I think Dr. Amish is held up somewhere. So he's supposed to do the panel.
I have a very clear question to everyone, starting from Ghanshyam, and Bharat is also joined. In a early stage, NCCN talks about giving Dostar also with Paclicarbo. In a stage 3 patient, EC, DMMR, will you give Dostar with Paclicarbo?
You mean for early stage?
Yeah.
After surgery?
Yes. I'll show you NCCN guideline also.
No, so not at this moment also.
So I'll show you. I think, I'm telling you the problem with the NCCN is that they don't believe in poll till now. So I don't know if I am having slide.
There are poll also of different types. So all poll are also not good, no?
No. So Ghanshyam, now the biggest problem, previously there were only 4 known poll mutation. Now we have around 8 to 10. And every year now 1 or 2 is increasing.
Right.
So Bharat wants me to stop. So any
Okay. Yeah. So I think I will hand it over to Dr. Bharat. I don't think he needs any introduction. He's recently joined as a clinical director at GEM Cancer Center in Coimbatore. So, and he's going to talk about less common histologies in ovarian malignancy. So over to you, Bharat. Thank you for accepting and coming at a short notice.
Am I visible? Am I audible?
Yes to both.
Yes, to both. Okay, just give me 1 second. So thanks, Uma, and thanks, Bishwas sir. And congratulations, Bishwas sir, on your award. I think I'm meeting you online for the first time after the you got the award. So congratulations in person. And also for inviting for this wonderful topic. Uma has given me a very difficult topic. That is, she has given me less common histologies, which you don't get a ready-made PowerPoint easily. So she's made me work for this. Thank you, Uma, for
Bharat,
that.
I have a full presentation because I presented this is a Lions 8 Lion at Bhopal. So the
Uh,
TP gave me this top.
I should have known this. I should have asked you before. Anyway, so the thing is, anyhow, this is a short 15-minute presentation on a very large topic. So if you look at the WHO classification, we know that we have epithelial ovarian cancers, which is a common ovarian cancers which we are seeing. And I think 90% of our practice is still high-grade serous carcinoma. Remaining everything comes as 10%. That is the dysgerminomas, low-grade serous carcinomas, granulosa cell tumors, and even rarer are things like Sertoli cell carcinomas, and most of the benign ones do not come to us. But you can see it's a big laundry list of tumors that we see in ovary. But we do get one odd ovarian cancer, which is like Yorker for us. Every year we get at least one or two cancers which don't fall into any of these categories. So although there are many, I thought we should not be discussing, this the previous slides laundry list, because it becomes too difficult. So what are the less common histologies we see? We see mucinous, we see endometrioid adenocarcinomas, clear cell adenocarcinomas, some seromucinous, mesonephric-like carcinoma. I have never seen a mesonephric-like carcinoma in practice. Undifferentiated carcinomas and dedifferentiated carcinomas, yes, of late I have seen. Carcinosarcomas and mixed cell adenocarcinomas. One I have not added in the list is small cell carcinoma associated with hypercalcemia. That also, I think we see one odd patient every year. We see like one patient. So now all non-EOCs, I think every histology is considered. These are rare histologies in the epithelial ovarian carcinoma category. Now, non-epithelial, I think every single one is actually considered rare. Even the dysgerminoma is considered rare, although we do see quite often, we see once in 3-4 months, we do see a dysgerminoma coming into us. So Sexcott stromal tumors, all categories, germ cell tumors, or combination of Sexcott stromal and germ cell, small cell hypercalcemia related, small cell large cell variant, Wolffian tumor and Wilms tumor. Rarely, I have not seen these tumors in practice. So first, to approach this, we must give a good clinical examination to assess whether it's a feminizing or masculinizing tumor, and hormone assessment, whether the patient, it's a secreting tumor. And because this is a rare tumor, it's always good, to get a pathology review and to get additional tumor markers. Your CA125 alone may not be enough to start from CEA, but maybe alpha fetoprotein, beta HCG, LDH, inhibin B, CA199, HE4, whatever. You do other markers that may sort of guide you to the tumor histology, or it may be helpful in monitoring the tumor. Now, complete cytoreduction, whenever possible, remains a gold standard in less common histologies. This is something that, in a epithelial high-grade serous in stage 3, stage 4, we are always thinking of neoadjuvant, but in less common histologies, many of them are chemo insensitive, and so getting a good cytoreduction should be standard of care. But if we cannot get a good cytoreduction, then we must consider neoadjuvant even in these tumors. So in epithelial non-serous histology, let's start with mucinous carcinoma. There is limited retrospective data which suggests that they benefit from colorectal type of chemotherapy. Now, there was a randomized phase 3 trial, the GOG 241, this trial started, their idea was to accrue nearly 250 or 260 odd patients, but the trial stopped after accrual of around 50 patients, primarily because of poor accrual of mucinous carcinomas into the trial. Now, but we have some data which are published, most of it from retrospective data and comparison of, comparison of ovarian carcinoma type chemotherapy and comparison of uh, uh, GI type chemotherapy. And when we look at that, we see that most of the people have used Capox, Folfox, or paclitaxel carboplatin plus capecitabine, sometimes capecitabine alone. And the other cohort has patients with gynecologic type of chemotherapy, which includes paclitaxel carboplatin or cisplatin with paclitaxel, rarely carboplatin with cyclophosphamide or single agent carboplatin, which used to be popular some 10 years back. I don't think any of us really use it anymore. Sorry. I'm just closing this box. So what do we see when we use gynecologic type chemotherapies in a mucinous adenocarcinoma, be it progression-free survival or overall survival? So the left, the right is showing the progression-free survival and the left panel is showing the overall survival. Both are significantly improved when we use a gastrointestinal type chemotherapy. But please remember that these numbers are very, very small. These numbers are 50, 60 odd patients. And the only randomized trial that was started could not accrue and could not complete. So we do not have randomized data on GI chemotherapy versus ovarian chemotherapy in mucinous adenocarcinomas. But based on what limited data we have, the curves are widely separate and there seems to be a significant benefit of using GI type chemotherapy. So next we come to clear cell ovarian cancers, which is the other rare type of epithelial ovarian cancers. And adjusted for stage, the 5-year disease-specific survival, we all know is worse for serous carcinoma. So stage 1, stage 2, stage 3, stage 4, every stage they do poorer, and it's significantly poorer when they are compared to the high-grade serous carcinoma. So in view of poor outcomes, we know that we actually add chemotherapy even from stage 1. But ironically, clear cell carcinoma is less chemosensitive compared to high-grade serous carcinoma. And there is some retrospective data on radiotherapy also in clear cell carcinoma. So we chemotherapy-wise, it is still paclitaxel carboplatin. There is no change in that, but we use it from stage 1 also. We do not observe clear cell carcinoma of the ovary. There is some data for radiotherapy. This radiotherapy cohort of around 60 odd patients is both primary post-surgery and in a recurrent setting. So patients who received pelvic RT, that is the RT similar to what we would do in a, say, carcinoma endometrium after we have done a cytoreduction, that is a PHBSO and a cytoreduction. Similar sort of pelvic RT when it is given along with chemotherapy or after chemotherapy in primary setting or in the recurrent setting, resulted in a significantly improved recurrence-free survival. So there seems to be some role of pelvic RT at least in clear cell carcinoma. But again, this is retrospective data, non-randomized, and so naturally we do not really offer RT to everybody. But in a limited disease or in a recurrent disease which is limited, there may be role of RT in clear cell, which we must remember. Coming to low-grade serous carcinomas, these are also extremely rare carcinomas. Only 2 to 6% of epithelial ovarian cancers are low-grade serous carcinomas, and these benefit from hormonal manipulation. So HMT is hormonal maintenance therapy versus observation. Definitely, when you look at the progression-free survival, there is a advantage when you're using hormonal maintenance therapy after you have given chemotherapy or after you have completed the surgery. Now, in this particular group, the best benefit for the hormonal therapy in the low-grade carcinoma group is seen in patients who have not had complete cytoreduction. That is, patients who have high-risk disease with residual tumor post-cytoreduction actually benefit from hormonal maintenance therapy. And benefits are also maybe seen in relapsed recurrent disease because they are also chemo-insensitive disease and may not really benefit from second-line chemotherapy. So hormones may have a role in second-line or as first-line maintenance. Now coming to the non-epithelial ovarian cancer, initially the germ cell tumors. So we have a large group. That is, if you look at the WHO category, this is the these many groups are there. But we all know the common one that we see is either dysgerminoma, or rarely we see yolk sac embryonal carcinomas. Of course, we also see teratomas, sometimes mature teratoma, but we also see some immature teratomas. Immature teratomas are usually seen in younger age group, in pediatric population rather than adult population. So these are the first box is what we usually see. Choriocarcinomas in the ovary are extremely rare, but are extremely aggressive also. So what are the studies on ovarian carcinomas? So from what I could find out, there are a few studies with very, very limited number of patients. So 70 odd patients in one retrospective analysis, another one with 26 and 12. The Dimopoulos had the maximum number actually. They had some 126 patients. The chemotherapy is always platinum based. Mostly it is cisplatin based, and two trials have used only BEP or BE plus carboplatin. So what we can see is in both dysgerminomas do better than non-dysgerminomas in the ovary. And the dysgerminoma has nearly a 93% 5-year survival for the entire group. That is all stages put together. So the survival when you are using chemotherapy in dysgerminomas, either in the upfront setting or even in the relapse setting, is very high. And if you've used in the upfront setting, the foveal survival is above 90%. And in first line, when used as adjuvant in dysgerminomas, the survival is nearly touching 100%. So dysgerminomas are very, very sensitive to the BEP or platinum-based chemotherapy. But most of this data for BEP is extrapolated from testicular tumors. There are other agents like vinblastine, ifosfamide cisplatin, or bleomycin, vinblastine, platinum. So some other agents also could be used, but outcomes are excellent with BEP in all stages, and it remains standard of care. I did not add the pediatric data. There is a good amount of pediatric data, but again, non-randomized data for both BEP and the CCG-COG protocols of JEB, that is carboplatin etoposide and bleomycin. So JEB and PEB data in pediatrics also support the use of chemotherapy right from stage 1 for ovarian germ cell tumors, both in the adult and pediatrics. But the pediatrics have slightly different doses, lower bleomycin. It is a 3-day chemotherapy rather than a 5-day chemotherapy like we use in adult. But there are limited prospective and phase 3 trials in ovarian GCT. Coming to sex cord stromal tumors, again, there is a laundry list of number of histologies that comprise of the sex cord stromal tumors. But what we are always concerned is the granulosa cell tumor. Granulosa cell tumor itself has an adult granulosa cell tumor and a juvenile. The juvenile, you would not see the typical Karl Exner bodies. There will be a high mitotic index in the histopathology, a slightly different histopathology compared to the adult. But other tumors like the sertoli Leydig cell carcinoma, these are all extremely rare tumors which we don't usually see in practice. Now, stage 1 of granulosa cell tumor, there is a propensity matched analysis which is comparing a treatment for stage 1 with chemotherapy and without chemotherapy, and whether it is 1C1, 1C2 or 1C3, that is whether there is peritoneal fluid, whether there is capsular breach, whatever the stage, there is no great advantage of using chemotherapy in stage 1 granulosa cell tumor which has been adequately operated. So these are patients who have been adequately operated and then given chemotherapy. But this is a propensity matched analysis. And in this, there is no advantage of offering chemotherapy in stage 1 granulosa cell tumor. What about stage 2 to stage 4? There is a randomized phase 2 trial of paclitaxel carboplatin versus our BEP protocol. And this is the GOG 264, which is a randomized study looking at these two regimes. This is a consort diagram, not a big 64 patients study. And finally, the standard of care arm was BEP and 6 cycles of paclitaxel. So 4 cycles of BEP versus 6 cycles of paclitaxel carboplatin. Primary endpoint was progression-free survival. And this was a trial that was designed to demonstrate non-inferiority. So the trial failed to demonstrate non-inferiority basically because the confidence interval crossed over to the predefined limits. But paclitaxel carboplatin was better tolerated, and of course, it is an easier scheduling. This trial used the day 1, day 8, day 15 VO also. So the much easier scheduling. And of course, we know that the toxicity definitely is lower with paclitaxel carboplatin. So the paclitaxel carboplatin was numerically better, but did not meet the statistical criteria for the outer limit of achieving non-inferiority to BEP. But the lower adverse events definitely makes it preferable in older women. And OS data, this mature data was never reported for this trial. But again, the OS data from whatever the immature data seems to be favoring, numerically favoring the paclitaxel carboplatin. So now there is another classification of many tumors which have not been covered. What do we do with these tumors? We really do not have an answer because there are only case reports and a few case series on all this. So we really cannot have a guideline to say how we are going to treat these tumors. But for these rare entities, we have to treat with extrapolation from either epithelial ovarian cancer or germ cell tumors. So either paclitaxel carboplatin or BEP-based regimens. Ovarian carcinosarcomas, undifferentiated carcinomas, and other sarcoma-like histologies may be added with, may be treated with the addition of ifosfamide or etoposide to paclitaxel carboplatin, like TIP regimes or the VIP regimes may have some benefit in this setting. So many entities in the current WHO classification do not have a defined systemic therapy, and there is no phase 3 trials to guide us in our treatment. But complete cytoreduction remains most important prognostic factor across all the prognostic information that we have across all these histopathologies. Judicious use of paclitaxel carboplatin will achieve, or BEP will achieve good responses and long-term disease control, and even cure in most histologies. That is what is important. Both the germ cell tumors, these Escott stromal tumors like granulosa cell tumors, these are all quite chemosensitive, and we may have a good patient with good cure if we can get a good cytoreduction and back it up with a good chemotherapy. Addition of hormone and targeted agents will achieve long-term remissions in most patients who are low grade. So we must look especially for low-grade tumors. Role of radiotherapy is still undefined, but there is some sort of data in the clear cell epithelial ovarian cancer. So the bottom line is that should be a good MDT discussion in treatment sequence planning and chemotherapy. So the crucial point would be to discuss with all the specialists before we take a call on launching on treatment. Thank you very much.
Thank you, sir. So the floor is open for a couple of questions because due to time constraint. If any of the participants are having questions, please drop in the chat box.
Dr. Yasir writes, nice talk, Bharat.
Thanks, sir.
Thank you,
Thanks,
Dr.
Dr.
Amish.
Yasir. Thanks, Amish, sir. Sir, how come you're looking younger than
लुकिंग यंगर
Amish,
अरे
sir?
यार मोटा हो गया हूँ छोड़ अभी यहाँ रिकॉर्ड हो रहा है ज्यादा नहीं बोलेंगे
No, sir.
लेट्स
You're really
स्टार्ट
looking very
एक्चुअली
young.
my apologies Dr. Uma by Dr. Tarini Sahu also has a session right now webinar going on and there my session is at 7:45 and I just forgot that के ये आज का ही है मुझे लगा ये कल का है but can I share my slides and do we have all the panelists I see Advait here
Yes.
Yes, sir. So now we have a panel discussion on platinum-resistant ovarian cancer, a focus on novel therapeutic options. This session will be moderated by Dr. Amish Vora, sir, and joining him as a panelist, Dr. Jehan B. Darbar, Dr. Advaita Gora, Dr. Hemant Mutluri, and Dr. Biren Banerjee, sir. Over to the
Jehan,
moderator.
Dr. Advait, Dr. Hemant and Dr. Biren. Dr. Aditya Murli is not there.
Sir was Unable to join today, sir.
Okay, no problem. Okay. So we will start. So topic which is given to me by Dr. Uma is platinum refractory ovarian cancer. And my slides are visible. And when I'm moving the slides are moving.
Yes, sir.
Okay, perfect. Right. So, Advait, first I would like to ask you, has the definition of platinum refractory ovarian cancer changed, or do you think that it has remained the same? Dr. Advait? Hello? Hello?
Yeah, we can hear you, sir. I'll just check. Advait looks to be online, but I'll just ask him.
Dr. Jehan? Advait? Advait? You can hear us? Dr. Biren?
Yes, sir, I'm here. Dr. Amish, I'm here.
Yes, Dr. Biren. So, do you think the definition of platinum refractory ovarian cancer has changed?
Yes, and actually, the oncologist will be better suited in answering this question. But yes, we are having more tools now to understand the disease better. And then there are early indicators that whether a patient is stable or responding to the therapy or they're developing platinum resistance. Yes.
Right. We have Dr. Jehan joined. Dr. Uma?
Yeah, hi, sir. Hi.
Hi, Jehan.
Yeah.
Do you think that the definition has changed?
No, sir, I still keep the cutoff as 6 months. I don't think in my clinical practice the definition has really changed, but I still stick to the 6 months cutoff.
Okay, so assuming the patient has taken bevacizumab maintenance 9 months and then the patient has progressed. So some of these patients may be resistant to begin with and they are responded to bevacizumab. Similarly, I was also looking at that if you have given PARP inhibitor after stable disease CR or PR, and if there is a patient after 12 months progresses, do you think that patient may be responsive to olaparib and maybe platinum resistant? Now we are seeing this more and more. Bevacizumab you are using more, Dr. Jehan?
Yes, absolutely, sir. So that so the PARP inhibitor, I would stick to use it only in the BRCA or HRD subgroup. So that data for platinum.
No, assuming patient is BRCA positive,
Yes.
you have given chemotherapy.
And I would still think of definitely, sir, rechallenging with platinum after 10 to 12 month gap. Definitely.
Yeah, so that is a re-challenge after 6 months of gap. But my point is that has the definition in the era of PARP inhibitor and bevacizumab changed?
I don't think so, sir. I would still, use platinum, despite rechallenge platinum, but if it has been a 6, 8 month gap,
Okay,
definitely. Yes.
right. Dr. Hemant is there?
Yes, sir.
Dr. Hemant, what is your thought process on this?
Sir, if the patient has become resistant to PARP, they are automatically platinum resistant. So
they are automatically platinum resistant. Assuming patient has progressed after 12 months of PARP inhibitor.
So I will not re-challenge with platinum.
You will not re-challenge with platinum. Fair enough. Perfect. I think so. In era of PARP inhibitor and bevacizumab, I think the definitions are probably changing. Dr. Uma, you are there. Dr. Uma, what do you say if patient has progressed 12 months after olaparib and has received last platinum 8 months back? Would you consider as platinum refractory? Would you consider as platinum sensitive?
I would still like to challenge if it is more than 6 months.
More
That is
than
what I
six
do in
months.
my practice. And if it has been more than 12 months after stopping PARP, I would still want to give a try and see whether patient respond, because those who respond can have sort of, they do tend to do better is what I see.
Right. So, Dr. Uma, this is the paper which says that 15% of patients exhibit primary platinum resistance, do you see? I don't see 15% of patients not responding to paclicarbo in ovarian cancer. Do you think that this is too high? This is an Indian paper. As you can see, it's a consortium of different people,
I would agree with you. I don't think, I mean, I have not seen 15%. I would say less than 10% is what I would say. I would not be able to put exact number, but less than 10%.
Dr. Advait, are you seeing now? We have been seeing you. You have signed all the checks and you have given lakhs of rupees to people.
Yes, Amish. Bolo.
So, Dr. Uma and I, we were discussing, this is an Indian paper where they have said 15% of patients exhibited primary platinum resistance. In your practice, do you see 15%?
So, Amish, I don't see 15%. Actually, that value may be somewhat less than 10% where we see primary platinum resistance. And this is what we see in clinical practice,
Right.
where patients don't respond to the first line neoadjuvant therapy. That forms about 10% or less.
Correct.
Many a times we do need to add on other drugs like bevacizumab in that situation if we've not already added it. And many a times we've seen that these are those mucinous histologies who are very difficult to actually manage and treat also.
Understood. Okay. Got your point. Dr. Jehan, do you think that this BRCA1, BRCA2 positivity, MSH1, MSH2, do they anyway correlate with platinum sensitive or platinum resistance? Dr. Jehan?
I can't hear you because
So, Dr. Jehan, the mechanism which associated platinum resistance is, say, BRCA1, BRCA2, MSH1, MSH2, ERCC, RAD1, Fanconi, all these one. Do you think that BRCA positive patients are resistant to platinum, or you see there is no correlation between the two? I think Dr. Jehan is in and out. Advait? Advait, you have to unmute yourself.
Yes. So in terms of the BRCA-ness and response to platinum, I think there is a mixed kind of responses that we do see. So in patients who are exquisitely sensitive to carboplatin, yes, we do see that they, in a group of patients, if you have to say BRCA1, BRCA2 positive patients, they would be exclusively or extensively sensitive to platinum agents, at least in the first line setting. However, there is a group of these patients who have a very early relapse. Even if you have put them on olaparib as maintenance, especially the stage 3, stage 4 as what we use commonly in practice, many of these patients, those who relapse very fast, they do have some resistance mechanisms, and generally their responses to second line therapy are very poor. So that platinum sensitivity actually does not stand true even if you're treating these patients with olaparib and then you have a very fast relapse within 3 to 6 months. However,
Yeah,
there is another
yeah.
group in which you would have these long-term responses and
Absolutely.
continued response. So there is a subset in which the expression actually does not correlate with the platinum
Does
sensitivity.
not correlate. In Once Upon a Time, I had reached out to Dr. Sudeep Gupta and I said, okay, let's do a trial where we call carboplatin as Garibo ka olaparib. But olaparib is no longer now, restricted to Amir because we get all sorts of generic. But as Dr. Advait said very clearly, there is no direct correlation, or at least we don't understand the subset of these patients who on one side will do extremely well, other side may be doing very poorly. But I think BRCA and platinum resistance, we cannot label them right now. There are the different theories that why those 7 to 10% of patients are platinum resistant. Conclusion of molecular is that no amount of these molecular alterations, we should change any treatment. Advait, even if the NGS report, the molecular oncologist tells you today that this looks like that the patient will not respond to platinum, are you going to change your practice?
So in first line, Dr. Amish, it's very rare that we would ask for an NGS. I would
Suppose
generally
assuming
ask.
मेरा
Suppose
पेशेंट आपके
assuming,
पास आया,
suppose
मैंने
assuming,
एनजीएस करके
yeah,
भेजा आपको, हाँ.
yeah. So suppose the patient already walks into my clinic with an NGS report. I would not really look into that NGS report when I'm deciding first line therapy. Even
Understood.
if it says that there may be a platinum resistance pathway which may be active, we've seen the entire ERCC1 story unfold many years back when these molecular targets had come in. Now you have the ARID1A, which is also a marker for gemcitabine sensitivity. So there are multiple of these molecular markers where we can have a specific drug which may be more useful than the other, but it is something which I will not really take into consideration in first line. I think the BRCAness, the HRD score, and the HRR genes, these are the things which I would look at in the NGS when I'm deciding
First
first line therapy.
absolutely agreed. Dr. Hemant, Dr. Advait talked about ERCC1. I have seen ERCC1 70% platinum resistant. And in fact, few of my patients who are platinum resistant, when I have done retrospective NGS, ERCC1 was there in almost all those patients. Dr. Hemant, would you take any cognizance of ERCC1 when deciding first line treatment or no?
No, sir. As of now, I do not take ERCC into consideration while starting first line
Okay,
platinum.
perfect. I think that is important. Okay, Dr. Hemant, assuming the patient apart from HRD BRCA has done HER2 positive, HER2 test, and it turns out to be IHC plus. FISH you have done, FISH is also positive, and IHC is uniform 90% membranes positivity. Would you give chemo plus BEV, or would you give NHER2 in the first line? What would you do?
No, sir, that doesn't change my first line therapy.
Doesn't change your first line therapy.
Yeah.
Do you think that these patients will respond better to platinum? They will not respond, they will progress, or it doesn't matter as long as you are not going to change your practice?
They'll respond to platinum.
They will respond to platinum. Okay. Dr. Dr. Hemant is very sure that IHC HER2 3 plus will respond to platinum plus BEV. Dr. You agree with that statement?
Difficult that's a difficult question to answer. But yeah, if it is a first line therapy, chemo naive patient, I won't change based on HER2. If at all, if it is like a carcinosarcoma who's got a HER2 positive and it's a metastatic recurrent disease, then definitely I want to add a trastuzumab to it. Yes, but otherwise, if
So
it's
you
a
would
first
add
line like
trastuzumab in the
neoadjuvant.
first line? You would add trastuzumab, Dr. in the first line? Advait is strongly nodding his head. No, no, no.
No, if it is a recurrent metastatic disease, yes.
So if it is
If
a
it is
recurrent
not, and
metastatic
like it is a
disease, then why trastuzumab? Why not NHER2
Yeah,
directly?
TDXD,
NR2. Why not
NHER2.
trust?
So is there a role of trastuzumab, Advait, today in ovarian cancer?
I would say no. It indicates that this is an aggressive biology of the disease. Of course, when you have your back against the wall and you've exhausted other lines of therapy, that's something which we use. But we do have the pan tumor usage for a tumor agnostic approval for NHER2 now. So
Right.
between the two, I would go for NHER2 rather than going in for a trastuzumab single agent or in combination with chemotherapy.
Right. So Advait, assuming the patient is platinum refractory,
Yes.
and patient's HER2 comes as 3 plus,
Yeah.
your obvious choice would be probably NHER2 if the patient can afford,
Yes.
right?
Yes.
But if it is 2 plus, as you can see here in the bottom line, the 2 plus is 9.8 months as compared to 22.1 months of the median duration.
Yes.
I have given in 1 plus and 2 plus, and patients have not responded. And in fact, patients have given me galis and gone to other doctors.
Yes.
So would you give, or would you recommend those who are listening, that you would give in 2 plus, or you would wait for FISH if the FISH is negative and IHC 2 plus?
So 2 plus is like a catch-22, Amish. We've seen the similar kind of results even in the lung HER2 positive space, where
Correct.
even the HER2 2 plus in lung don't respond that well. The 3 plus is the one where I would use NHER2 in. If it is 2 plus, I would look at other options. I would look at fall receptor alpha. I would look at other options which are there, maybe even PDL1, because there is data that almost in 18 to 20% of patients, there is a co-expression of PDL1 along with HER2 positivity. So that story is still evolving right now. We've seen the same story in the endometrial cancer space developing, where dual anti-HER2 plus PDL1 inhibitors are being used. So that is something which I would explore before I decide to give NHER2 for a 2 plus patient who is fish
So
negative.
NHER2 for 3 plus, yes, yes.
3 plus fish positive, yes,
NHER2
yes.
plus fish negative, no.
No, the
Okay,
magnitude
perfect.
of benefit is not there. So as I said,
Magnitude of
if
benefit
that
is
is, if I don't have any other option like a last resort, yes, I may give it, but with the clear-cut explanation that it may not really work.
right. Okay. Dr. Hemant, what would be your drug of choice in platinum refractory chemotherapy? You would give liposomal doxorubicin, topotecan, or gem alone, or gem plus paclitaxel. What would you give?
Sir, my first preference will be liposomal doxorubicin.
Liposomal doxorubicin. And
Yes.
if the patient has not responded, what percentage of patient will respond? You have the table in front of you, multiple different years. And if the patient is platinum refractory, any amount of chemo, you have a response rate of around 15 to 25%. So, Dr. Hemant, you agree on that point?
Yes, sir. I'll agree.
Okay, Dr. Hemant, since you are there, this Aurelia study of 2014, it was very interesting, and it was presented in ASCO 2012. If you see annual 12 meeting bottom, and they said randomized phase 3 trial bevacizumab with chemotherapy for platinum resistant recurrent ovarian cancer. Would you give all your patients of platinum refractory bevacizumab, Dr. Hemant?
Yes, sir. I add bevacizumab to all my patients.
All your patients. Okay. Dr. Advait, you would add in all of your patients? Okay. Dr. Uma? Dr. Advait, you would add, based on Aurelia 2014 study, all your patients bevacizumab with chemotherapy, or you say no, not all patients?
So I would not look at all patients. I would select these relapse refractory patients very carefully. Patients who have signs of subacute obstruction, I would be very careful. Otherwise, it's a drug which we have learned how to manage. As long as you're selecting your patient properly, the addition of bevacizumab to a chemotherapy in a platinum resistant space does add benefit, and it works as synergy along with what chemo partner that you're using. But the patient selection has to be very careful. You don't want patients with subacute obstruction, because bevacizumab itself can worsen the subacute obstruction at times. That is what we've seen in practice.
Agreed. So patients, what I do in my practice, if the patient is eligible for bevacizumab in a platinum refractory, if we don't have mirvetuximab option, I add bevacizumab to all whatever maybe. I have not seen a better forest plot chart than Aurelia, but somehow we have, sort of undermining the role of bevacizumab in that. Of course, in NGS, if we have an NTRS target, it is definitely there. And the flavor of the discussion is this NEJM, mirvetuximab soravtansine in platinum resistant ovarian cancer. Advait, category 1 recommendation?
Yeah, category 1 recommendation, but a difficult drug for patients to tolerate. It's not easy.
Not easy. Looks like you have dozens of them.
About 4 patients, but
Okay.
but unfortunately, none of them have gone beyond 3 months of therapy. Of course,
Okay.
most of them were third line and beyond, because we had no other option, and patients were also willing for that kind of cost to be borne for the therapy, because currently it is beyond reach of most of our patients.
Right. So I have two patients. I'm half of Advait, and one of them have crossed fifth month now. I'm
That's good.
keeping my fingers crossed. But as you rightly said, it is a difficult drug. You have to monitor a lot. Dr. Hemant, any personal experience of mirvetuximab?
No, sir.
Okay. Dr. Jehan is there or he has still not able to join? Okay, Dr. Jehan looks like he's traveling. So this is a forest plot chart. If you see, if the patient is platinum free interval is less than or equal to 3 months, the drug works well. In fact, irrespective of less than 3 months or less than 6 months or more than 6 months, the drug works quite well in terms of the disease progression, which was the primary endpoint. So in the first time in 1 decade, we have this overall survival advantage. So platinum refractory, second line category 1, platinum sensitive, second line category 2A. It is still not category 1. So that is what we need to understand and we need to see that. And now we come to surgery. Dr. Biren, in you mentioned about the oncologist. Sorry, my apologies, but your specialty is Dr. Biren? Dr. Uma, Dr. Biren is gynae surgeon.
Molecular oncologist, sir.
Molecular oncologist. Okay. So, hey, Dr. Hemant, when would you platinum resistant disease? When would you do cytoreductive surgery?
I usually do not prefer
You
to
usually do
send the
not
patient for
prefer.
cytoreductive surgery. Only if
Okay.
only if there is a possibility of optimal cytoreduction, I may consider if there are.
You may consider it. Advait, what practically, how many patients it is possible to send to have an R0 resection when they are platinum refractory?
So it's not a very common thing. Generally, these kind of surgeries happen when patient is inadvertently explored for something else, and then the surgeon realizes that okay, this is doable, and we are able to get a complete R0. So many a times, whatever few cases that we've commonly treated with our surgical oncology team at SAIFI, we see that. Patients were in obstruction, they were operated for an exploratory lap, and then it was found that okay, the peritoneal disease also seems to be resectable and there is nothing else anywhere. So along with the bowel resection, they have done the peritonectomy also.
Excellent. I think this is what I don't remember last when was my platinum refractory patient. We could see that the patient is R0 resection, but yes, there is no harm in
It's very
going
rare.
to
As I said, it's very
very rare.
anecdotal. It's just something that we can count on a
But
finger.
there is no harm. Anyway, we discuss all these cases in tumor board, so there is no harm in surgeon having a look at it. One of the anecdotal cases of R0 resection, in fact, the overall survival increases by 10 months. So we should not miss that window of opportunity. Dr. Hemant, re-challenge of platinum-based chemo, assuming patient is platinum refractory. I have given this patient PLD and patient has responded for 9 months. Would you re-challenge with platinum? It is platinum refractory.
I do not re-challenge with platinum, sir.
You do not re-challenge. If it is platinum sensitive and if there is a platinum now become resistant, and if the 6 months has passed, do you re-challenge, Dr. Hemant?
Yes, sir, I will.
Then you would re-challenge. Advait?
Yeah, so this was a strategy we used to use initially before when we had very few options, and I still look at re-challenging platinum if that 6 months boundary has been crossed. So even if there is a patient who is platinum resistant, and I have got a 6 months of platinum-free interval, I would re-challenge with another platinum agent just to see how the response has been, whether we are able to get a drop in CA125, get a response in terms of radiology, because eventually platinum is the backbone of therapy irrespective of whatever we say in terms, because that platinum resistance is actually a relative term. That is what I believe.
I agree with Advait. In fact, ovarian cancer patients, they live long. And sometimes you have 9 lines of chemotherapy and 8 lines of chemotherapy and you exhaust everything. So that is something I also do if there is 7 to 8 months good past, and I re-challenge with platinum majority of the times because we need to find options. Advait, anytime you have used apart from MSI non-high, MS stable, have you used immunotherapy in ovarian cancer patient?
So currently there is a patient whom last week I have counseled them based on the keynote B96 data which has come out. Now, this lady has a BRCA1 positivity but had failed on olaparib maintenance, has undergone cytoreductive surgery twice so far, but she's got a TMB of 30 and she's got a PDL1 score of 28%. So that's when she had come to me. She has exhausted about 6 lines of therapy. Her fall receptor alpha level is 25%, which is negative because it's less than the 75% cutoff. So in this situation, and she's exhausted gem, bevacizumab, irinotecan, cisplatin, carboplatin, and even oral metronomic that we had given her. So currently, I have advised her to go for the treatment with Bev and Pembro as a combination, and maybe add carboplatin based on how she would.
So Advait, drop me a personal message because 4 of my last patients on immunotherapy in ovarian cancer, not a single one has responded.
Yes, so
Exactly
I
same
have
like
explained to her the same thing, that I don't know how the responses have been.
Yeah.
This is a
No,
new
not a
data.
single one responded, and they all
Let
said कि
us
sir
see how
आपने
it
15-20% बोला था क्या हो गया? But you know that is what the life is. But if your patient response, do let me know.
I
You know
will
we
let
learn
you
from
know.
each
Yes.
other. This is my last slide. It's a platinum resistant or refractory ovarian cancer. You give single agent non-platinum chemo with BEV based on Aurelia study. Whenever patient progresses and fall receptor alpha is positive, more than 75%, mirvetuximab. If FR alpha is negative, do TP53. If TP53 is wild type, give gemcitabine irinotecan. If TP53 mutation V inhibitor, which we don't have, plus bevacizumab, in fact, we end up giving gemcitabine plus minus irinotecan. I have given quite a few patients of irinotecan plus bev, and they have responded for 8 to 9 months. And after that, oral cyclophosphamide, tamoxifen, all that we do, and keep looking for targets and keep looking for newer place. With that, I close my panel. And thank you very much, the panelist. Jehan couldn't come on the line. My apologies. Aditya was not there. Dr. Biren, I didn't know you are a molecular oncologist. My apologies. Otherwise, I would have got some questions for you. Sorry for that. And thank you, Dr. Uma, for giving me this opportunity.
Thank you, Uma.
Thank you, sir,
you,
for a
Anish.
wonderful discussion. Thank you.
Thank you all. Thank you all the panelists and moderator. Now let's move on to our last session of the day. Next, I would like to welcome Dr. Ghanshyam Biswas, sir. Before handling over the session, I would like to take a moment to acknowledge the leadership of IAIO, the International Association for Integrated Oncology, under the visionary guidance of our president, whose leadership has been instrumental in shaping IAIO into what it is today, a globally connected platform for oncology education, research, and collaboration. With that, I now invite Dr. Ghanshyam Biswas to kindly take over and lead the important discussion along with our esteemed panelists. Sir, over to you, please.
So thank you, Roshni, for those kind words, and thank you, Uma. So I don't see Chandrakant there. So I could see Dr. Praveen, Dr. Mayur, Dr. Ashish.
Sir is joining in a minute, sir.
Please let me know when Chandrakant joins, right?
Yes, sir.
So eradicating cervical cancer, where are we? So I think it is a difficult topic. And so Dr. Ashish, Dr. Mayur, Dr. Chandrakant, and Dr. Praveen. So the global burden of cancer. So on one side, you can see the incidence of 20 million new cancer cases as per Globocan 2020, and around 10 millions in spite of all advancement in oncology or in science, you can see. So in short, so if we take the cancer cervix uteri, so is one of those common in terms of first 10 topmost cancers in terms of incidence, and so it is true for the mortality also within the top 10 mortality. The scale of the problem, cervical cancer, the world and India, on the left-hand side, you can see, so around 6.5 lakhs, again, 50% of the patients are dying. Unfortunately, in 100 countries, you can see, so these cancer ranks the top 3 cancers. And if you see the 2030 predicted, so we are going to have huge number of cancer cases in spite of, we see in the subsequent slide, the screening and the vaccines that are available. So one woman diagnosed with cervical cancer every minute, more than 75,000 women dying for cervical cancer every year. So 9 women dying of cervical cancer every hour. So, and if we, on the right hand side, if you see our country, so we contribute around 1/3 of the cancer cervix in the global map. So around 35% of the global cervical cancer burden is from India. And if you put China together, then probably it constitutes almost 50%. So highest estimated number of cervical cancer deaths has been reported in India. So every 7 minutes, one Indian woman dying of cervical cancer. So if you put together the cumulative risk, so 2.5% in women is the lifetime risk for getting a cervical cancer, and almost 1.4% cumulative death risk. So now, how common is cervical cancer in your practice? Stage distribution you see, and do you come across precancerous lesions? So we will start from Dr. Praveen.
Good evening, sir. So in our practice, it is still the second most common malignancies that we see in women. So same like the national prevalence, the incidence and prevalence in our practice also, we still see quite a lot of cervical cancer. And we most commonly see in the locally advanced setting. Almost 60 to 70% of our women whom we see are locally advanced at initial presentation.
So do you come across precancerous lesions refer from your, or you come across gynecologists?
Yes, sir. So we do have a dedicated gynecological oncology department, and they handle the precancerous lesions, sir. It doesn't come to medical oncology.
Right. So Dr. Ashish, so any change in opinion? Anything you differ?
Second most common malignancy among females, and most common stage, of course, stage 2 and stage 3.
Right. So now understanding the cancer biology, so starting from PDL1, MSI, MMR, TMB, HER2, NTRK, RET. So all these are in place for a metastatic cervical cancer. So the biomarkers and the tumor agnostic. So now, are we more focused on advanced cancer? So we don't talk about screening, and we don't talk about, I don't know why, how Uma choose these topics. So do you understand the biology better today? So Dr. Mayur.
I'm practicing gynecologist and gynecologist, so I think I am the one who looks after a lot of precancerous lesions and all those referrals before I had to send them to either a radiation oncologist or a medical oncologist.
Right.
Conventionally, in all cancer-related disorders, the focus was always on a more advanced stage coming down to the early stages, and that's how the treatments have always evolved. We are talking more about the molecular profiling and molecular or immune therapies and everything. But still, we are very far from the basic biology that we have known that it allows a 10 to 15 or even sometimes 20 years of screening and treatment of early pre-invasive lesions, which we are not yet emphasizing on.
Right. So do you agree as a gynecologist? So you see endometrial cancer, ovarian cancer. So do you understand biology better today in 2025 in regards to cervical cancer?
I'll not say that, sir. The research on cervical cancer biology has been there for last 10, 15, 20 decades. But since we are still into not achieving that preventable stages, we are not going ahead. So many of the biomarkers like P16 based screening modalities are all coming into screening and early diagnosis modalities. But compared to advanced modalities into treatment like CA endometrium, where we have a molecular profiling and a lot of chemotherapy regimens, that is not yet calculated in cervix.
So now understanding cancer treatment evolution. So you can see, so if I'm talking about advanced cancer, so we have a first line, we have a second line and subsequent lines. So the incremental improvement in survival in treating first line cervical cancer with combination has not, even in ovarian cancer, we have not seen. So 2009, so chemotherapy backbone was platinum taxane. Then we added bevacizumab in 2014. Then we added Pembro in 2023. So what has evolved from a response rate of 30% to an overall response rate of 70%. So it was neither seen in ovarian cancer nor probably in cervical cancer. And the OS of 12 months to almost like 30 months when you are adding, we have seen in the keynote 8 to 6. And the therapies in development for recurrent metastatic cancer. So there's a hell lot of from phase 1, 2, 3 and approved indications. So not only the IOs, there are cell therapies. So there are DNA vaccines, therapeutic vaccines, we'll see. And also there is an ADC in place, that is tissue tumor vedotin. So the cervical cancer, the whole summary. So there are dysplasia when like our colleagues like Dr. Mayur will see these patients, even the early disease will go to them, then probably the medical oncologist role and the radiation oncologist role comes in the locally advanced, and then the whole metastatic disease will be in our forte. And the pivotal practice changing the landscape of the locally advanced disease, the first line, second line, so moving from anti-angiogenic checkpoint and the antibody conjugates. So do you feel the focus has drifted away, Dr. Praveen? And are you happy with the jump made in advanced cancers?
Definitely, sir. I strongly believe that improvement in outcomes is mainly influenced by trials involving immunotherapy drugs. I think that we can see these days in even locally advanced settings also. So the single most important drug class remains immunotherapy as of today's practice, and that has shifted paradigms by a lot across stages: recurrent metastatic, persistent, and even locally advanced cervical cancer today. And
So
we are
Ashish,
really happy with the magnitude of benefit that is seen with the
right,
immunotherapy drugs as well.
right. Ashish?
Sir, definitely happy with the jump in advanced cancer, but would like to see more of early stage or even pre-cancer condition in which we can give a better result. We all know that the cure rate decreases with increasing stage of the disease. So this outcome is definitely better as compared to what we have before. But earlier stage or even pre-cancer, and definitely our focus should be on prevention more than the cure.
Right. So that we have a risk factor starting from HPV, low socioeconomic status, poor personal hygiene, nutritional deficiency, multiple sexual partners, so high risk male partner, immunodeficiency, HIV, and the sexually transmitted disease, so tobacco uses and certain genetic factors. Has Chandrakant joined, Roshni? No?
Yes, sir has joined now.
Okay. So, Dr. Mayur, so do you think anyone in isolation or in combination is responsible for this large number? And which one of these is bothering us more today? And do you think we lack common sense, lack awareness, or lack of structured screening program?
Sir, some or other way we are, all of them are involved. So you just spoke about all the risk factors. At the end, it accumulates into the degree of HPV exposure and the persistence of HPV infections. There will be some genetic factors, nutritional, hygiene, at the end, socioeconomic status, and immunodeficiency, which will kind of enhance the role of HPV to cause a oncogenesis. Tobacco also increases the same oncogenesis risk. So basically, we are culminating on the HPV as a culprit. And when we look at the HPV, it's not the HPV infection, it's the HPV persistence that causes the cancer. So we have the screening programs which are there in the multiple countries. In UK, NHS has implemented it very nicely initially with cytology, now shifted to HPV. But even Bangladesh learned from India the art of doing visual inspection with acetic acid and started their program and made a dedicated referral units. But we as a country have not gone ahead with the screening program at all. Even with vaccination, the awareness and the structure from government to implement the vaccination is not there in majority of states. Right now, few states have picked up, but it's still not going ahead that aggressively.
So, Chandrakant, if you find, so do you think we lack common sense, lack awareness, lack of structured screening program? Though Dr. Mayur has already contributed to that. So, Chandrakant?
Yeah, I agree, sir. A lot of all this is important. Common sense is, of course, important. Awareness is equally important. I agree, lack of common sense. I mean, there are multiple sessions where making out of, common sense is lacking in oncology, or even common sense in oncology is a
The
separate,
common sense oncology, what Dr.
yeah,
Bhavna has
it's a separate webinar series.
Okay,
So, yeah, I agree with you, sir.
right. So cervical cancer and HPV is like an aloo pyaj. So this mostly happens when there are repeated exposure to HPV. So there are over 200 strains, and you know the transmission. So, but not all HPV strains causes cervical cancer. Some are present but die out, causing any DNA damage, while others are very high risk. But when high risk strains such as 16 and 18 infect the cervix, they can lead to certain cellular changes that could develop into cancer. So your take on HPV vaccination and any personal comments? How early or late in age for vaccination? And second will be your take on primary versus secondary prevention. How early or late in age for a secondary prevention? So Chandrakant.
Right, sir. So I think so. The earlier it is, the benefit is more. Before the familial life is started, that is when you get exposed to the high risk strains. And how late? Like, I think the age is something like 13 to 15 years in the Western world. In our world, it's a little bit later. And what about elderly, like 50s, 40s? I think even there, if someone is willing for the vaccination, understanding that the benefit is not that much, it can be given, because we really don't know to which viruses they have developed the antibody. So the benefit is lesser in the later age group. But if someone is voluntarily willing to take, yes, I would say you can take.
Yeah, so as an oncologist, so we try to counsel our patients' attendance. So I personally put this as a personal comments that would you any of these four panelists, so they have vaccinated their girl child, the boy child, their wife. So that was my reason. So do you believe? And that belief comes if you are vaccinated only. So I have vaccinated both my girls, so my daughter and my daughter's cousin. And even when the vaccination was, when it was a huge cost, so though my wife was 35 plus, so I did vaccinated her. So I don't know, so we know that. So as later in the life, so the it is not going to be effective. So that was the reason any personal comments. So as an oncologist, practicing oncologist, Dr. Mayur, Dr. Chandrakant, anybody, Praveen, so Ashish, so you can just have a comment, because many a times we advise mammography, we don't follow that. We advise vaccinations, we have not followed that.
About vaccination, the immune response is very different with the younger age and with the advanced age. So there are adequate studies that, specifically from India as well, which says that in the younger age of 9 to 15, even a single dose vaccine is quite effective, and we can avoid 3 doses. But same as age advances goes to bracket of 18 to 26 or above, the doses required to have an adequate immune response is less. So we need more and more doses. So that's first about the younger age. Uh, Irrespective of what age we have vaccinated these girls and everything, the vaccine effect is never 100%. So we cannot just exclude the patients by giving vaccine. Uh, like you asked, ki how many of you have given the vaccine to your family members? In routine organic societies, I ask how many of the patients or doctors, female colleagues, have underwent an HPV test in last 5 years.
Right.
So
You're
this cannot be. It needs to be double-edged thing where we give the primary prevention with vaccination, and we implement the early diagnosis and screening with HPV tests or with liquid-based cytology.
Right. So my question was primary, what is the youngest age? So younger can be as early as 9, and the maximum age that was 45, though we discussed that beyond 27, when married, when have a children, so less benefit. In terms of secondary HPV testing and PAP testing, so the earliest can be 21, and beyond 65, so there is no screening. So that these are the recommendations, and we'll go. So what are the recommendations for 21 to 29 and ages 30 to 65 and beyond 65? So these are the guidelines for cervical cancer screening program. So HPV testing as a primary screening target. So from 21 to 29 years, screening every 3 years with cervical cytology alone, and beyond 30 to 65, then you have every 3 years cytology alone, at 5 years HPV testing alone, and then again 5 years in combination. So consider previous patient's health history in selection of the testing frequency. So these are the cervical cancer primary prevention. So global HPV program, 149 member states have introduced. Almost 27% of girls have received at least one dose of HPV vaccines. So by HPV vaccination, what are the other cancers that we can prevent? Our role as an oncologist. So Ashish.
So, yeah, of course, we have vaginal, vulval, anal cancer, and oropharyngeal cancer. And our role as an oncologist, of course, is very important. HPV vaccination, what I do is I also counsel the male, whatever male individuals which I get. Another talking about the HPV vaccination, the society where I live, I've rolled out one schedule here where most of the females they have received HPV vaccine. Another thing which I do is for almost all of my patients, irrespective of the primary malignancy, whatever they are having, I counsel for HPV vaccination for their daughter's son, because we know the carriers, from where the females are getting HPV, it's from males. So it's very important to vaccinate them also, and also to decrease the overall contribution of HPV-related cervical cancer counts around 20 to 25% from India. But if you talk about other HPV-related cancers, that also leads to around 20 to 25%. If you talk about anal cancer, oropharyngeal cancer, so those things are also very important, sir.
So 90 to 90% of HPV positive cervical tumors. So it can have a vulvar, rightly said by Ashish, vaginal, anal, penile, oropharyngeal, tonsillars. Based of the time when it comes to an oral oropharyngeal, so they have a good biology. So we can de-escalate your treatment. And so 70% of HPV tumors are 16-18, and out of that 50% is contributed by HPV 16. So cervical cancer screening, your preference as a modality, since we have the surgical oncologist, so Dr. Mayur. So ultrasound, colposcopy, biopsy, so when? So just in nutshell.
For screening, the preferred modality right now, what we are following is HPV. Being a DNA-based analysis test, it is very sensitive and has a reasonable specificity as well. Ultrasound per se, there is no role in cervical cancer screening modalities, because something that you can see with direct naked eye, why you want to look through a machine? So that's a big question that a lot of people look at it. Sonography shows a bulky cervix. No, we don't need to see that. We need to put a speculum and see cervix directly. Biopsy is either when you see a frank growth, or if you have a colposcopy which is showing a high risk area.
Right. So the cervical skull scan is screening and the histological classifications. So there can be an infection. So these are basically negative. You have a precancerous conditions from mild to severe. This can be labeled as CIN1, 2, 3, and there are frank cancers. So now, so visual inspection. So this is one of the NEGM paper of 2010 with acetic acid, HPV testing, and conventional cytology in screening of cervical cancers. And this was in collaboration with TMC Mumbai and Varshi. So the hazard ratio of incidence of stage 2 cervical cancer and cervical cancer mortality from 2000 to 2009, if you see this graph on the left hand side, so this was in Maharashtra, one of the district was Usmanabad. If you see the VIA, the cytology and HPV. So VIA was positive in the significant patient population, and then cytology and HPV was on the lower side. And if you see the cumulative mortality for screen negative, again, so the graph remains the same. So the effect of visual screening on cervical cancer incidence and mortality in Tamil Nadu. So this was one of the first papers in Lancet 2007, Shankar Narayan. So first study to show that impact of VIA screening on cervical cancer mortality. So red diamonds are for the control group, and the blue one is for the interventional group. So shows that, so VI, as Dr. Mayur rightly said, so the VI screening significantly had a significant reduction in the mortality. So is there a role of therapeutic vaccine for a cervical cancer? So Dr. Praveen.
Sir, as of now, not outside clinical trials, sir.
Right. So no therapeutic vaccine is approved yet for cervical cancer. So there are research. The goal is to treat existing HPV-driven lesions, not just prevent infections. So there's a big list of these 5 vaccine and the platform. And if I summarize these, the cervical cancer vaccines, so promising in CIN3 is BBVAX 001, which reduces the need for invasive procedure. So in advanced disease, so there is a vaccine with immunotherapy that is durvalumab shows meaningful responses. Long-term survival signals with the Lovaxin C shows a durable outcomes in a subset of patients, and diverse platform driven innovative in immunotherapy for cervical cancer. So these are in the experimental way. So probably these will have something in the future. So what do you mean by elimination of a disease? So Chandrakant. Dr. Praveen?
Sir, I believe the WHO defines it as less than 4 per 100,000 women years as criteria for elimination of a disease.
Right, absolutely. So incidence of a specific disease is so low in a defined geographical area as a result of direct intervention that it ceases to be a public health problem. But continued intervention measures are required to keep the disease low, and we know the example of smallpox, polio, and diphtherias. So this is the prevalence of cervical HPV in a sexually active woman from 15 to 59 years, and this is from 1995 to 2011. So you can see the Bhutan, which has been and a prototype example will show, and even if you see our India is mentioned as 1891. So year 2030 as a target for cervical cancer elimination. So anybody, so Dr. Mayur, any thoughts on that?
The WHO and the other collaborators have started this program, the 90-70-30. So it includes screening of 90% of the girls' vaccination, 70% screening with a high specialty and high sensitivity test, likely to be an HPV test for around 70% of the patients, and treatment of at least 90% of these patients. Target is to reduce the mortality by 30%, and out of the 70% patients who are screened, 90% are treated for these CIN lesions.
Absolutely.
When we look at the parameters for screening, the target is 70%. The Indian stats somewhere range between 2% to 5% to 0.3% in different states right now. The best being the southern states. So we are far from that for screening perspectives. For vaccination, government, specifically state driven mechanisms have taken a good role, especially in Delhi. I think recently Tamil Nadu is also entering the thing.
Right.
Assam had started a long time back. So these states-driven programs specifically targeting the school age girls is going to vaccinate these girls by 15 years. And with the advancing studies coming from our area as well as from sub-Saharan areas where even a single dose vaccine is very effective, likely the government is going to target school age girls with a single vaccine. So achieving the part one of vaccination is achievable with a government-driven program. Yes, definitely. What makes the difference is the achieving the second part, because right now in NCCD program, the last government stat says roughly 12, sorry, 1.2 CR women from the eligible group has been screened. So of a country we are 100 CR plus population and 50 CR plus eligible patients for screening. We are hardly 2% of that.
Right. So rightly said by Praveen. So below 4 cases of cervical cancer per 100,000 human years, and as Dr. Mayur said, so 90, 70, and 30 is the target. Say a world without a cervical cancer, we are only 5 years away from that, but it's a difficult goal definitely. So challenges for cervical cancer elimination, vaccine hesitancy, is it real? And though we have already touched upon, what is your take on 1, 2, or 3 doses of vaccine? So Chandrakant, if you are there. Or Praveen?
So I'm there, sir. Sir.
Chandrakant, please. ओपीडी में पेशेंट देख रहा है तुम
नहीं सर हो गया
हो गया
right, so I think still there is a the challenge for elimination is vaccination is still not realized that it is an important thing. Like even among oncologists, we feel that it may not reduce the mortality. So these are the some roadblocks still we have. We need to have more awareness and a convincing conviction before we write, and also among awareness among the general population also. Outreach programs, they would help in universal vaccination. So even the males also can be vaccinated. So these are the, because if you vaccinate the males, again the HPV virus won't be transmitted. So by doing
Yes,
this, I
the
think
biggest roadblock is a vaccine hesitancy. So what is your take on
right, sir. Agree, sir. Hesitancy is the biggest.
Okay. So Ashish, what is your take on 1, 2, or 3 doses of vaccination?
So basically, say ideally, to before 15 years of age, we'll go for two vaccines, two doses. Beyond 15 to 26, three doses. But if the patient cannot take two doses, even one dose is good enough because we have 10-year data now. So in those patients, definitely one dose can be also be a good option.
Right. So the challenges has been vaccine misinformation, anti-vaccine campaigns, perceived excess harms, vaccine hesitancy, vaccine prices, availability issues, and the declining incidence. So cervical cancer low in political agenda, no advocacy from women or the women parliamentarian, lack of awareness, lack of healthcare infrastructure for screening program, cost of HPV testing, inadequate trained personnel, no culture for screening, lack of diagnosis and treatment capacity. So very poorly developed and accessible cancer diagnosis, which Dr. Mayer already touched upon, so that we are far away from that, and treatment facilities in many low economic countries and the states, and the fragmented and inadequate healthcare financing. So the effectiveness of less than 3 doses. So you can see the HPV 16 and 18, which is the main strain, you can see. So the lower curves are for a 1. So again, so adequately. So even if it means shows that in short, if adequate one dose is probably good enough, though. And for the rarer strains also, the HPV 6 and 11. So even somebody has received one doses, and this has come from a retrospective collection of all those patients, all those individuals who took one vaccination from the government schedule, and this is how the things were analyzed. So evaluation of less than 3 doses of HPV vaccination in India, frequency of persistent HPV 16 and 18 in 2,400 vaccinated women by the dose regimen. And if you see 3 doses, around 0.1, 2 doses 0.1, even 2 doses 1 and 60 is 0.3, 1 dose 0. So all vaccinated girls 0.1. So the starking difference is, so 1 or 2 or 3 is not the difference. The difference is between an unvaccinated, which is 1.7 almost, and versus somebody who has received at least one. So at least this shows that somebody who has received at least one doses, so is a good enough of the vaccination part. So incidence rate of CIN3, so this was from the BMJ paper 2017 for those HPV 16 and 18 vaccinated, unvaccinated. If you see the CIN3, so 4 versus 75 in unvaccinated, cervical cancer 0 versus 3, and so this shows a significant. And in terms of, so that was CIN3, and this is in terms of cervical cancers. So for a vaccinated patient, cervical, vulvar, oropharyngeal. So this is from one of the studies. HPV-related invasive cancer was 0 as compared to the number mentioned about 20 there. So vaccine efficacy for HPV-related cancer, not only cervical cancer, was 100%. So do you think we are better aware today? And is the incidence going down? So do you need to resort to such terms like Ms. Poonam Pandey? Chandrakant?
Yes, sir. So yes, sir, we are more aware today, definitely. We are talking about it in conferences, events. The awareness is there. And the incidence, yes, I think the cervical cancer incidence is coming down because of hygiene and screening, and also because of vaccination programs. Uh, I think Poonam Pandey, I don't know, sir. That's more pessimistic that someone died of cervical cancer. I'm not sure that's the way to do.
Ashish,
But yes, the awareness is there. It wasn't there before.
Sir, our awareness to sir was always there since the time HPV vaccine was there. Doctors are always aware. It's the general population's awareness that is important, sir. I don't think they are aware at all because the single digit outcome which we have achieved for 90-70 strategy, if you talk about vaccination, that is in the tune of 1 to 2%. Screening, again, less than 10%. Treatment also less than 10%. So awareness to general public is definitely lacking, sir, and definitely a lot needs to be done regarding that.
so Praveen, who was Poonam Pandey? So clear it for Chandrakant.
I am not aware of this stunt by this.
Okay, so I'll show you. So what we could not do, so they did it. So on the left hand side is Angelina Jolie, and we know the whole BRCA story because her mother had a CA breast, so she was detected to be G BRCA, and then subsequently she underwent bilateral mastectomy and subsequently prophylactic oophorectomy. So Poonam Pandey is an actor, so who hoaxed for a cervical cancer and death. But so this was, and those 2 days, you can see the Twitter, the Facebook, everything was flooded, and people went through about cervical cancer and vaccination. So she alive and healthy. So she hoaxed in regards to a cancer vaccine or cervical cancer vaccines promotion, you can say rightly. So it's all about cancer. Let's not shy of the facts. And this many of you know, this is Taira Kashyap, who did it for the breast cancer. So somebody did for the breast and ovarian cancer, somebody did for cervical cancer, and Taira Ayushmann Khurrana's wife, who had breast cancers, and so loss of hair and surgical scar. She posed against her family wishes just for the sake of common men. So there are many celebrities who doesn't come out, but these are people who came forward, and thanks to these celebrities. So can we prevent cervical cancer? Any recent? So we are talking of infections, persistent. So can we prevent cervical cancers? We are talking about vaccine. Any recent evidence? Your take on HPV vaccination and long-term toxicity and infertility. So Dr. Mayur.
So while we are talking, Sweden have already done it. Last
Okay.
5 years, Sweden shows no single CIN3 plus disease. So Sweden have declared that it have eliminated cervical cancer, and mainly because of screening and HPV vaccination for both girls as well as boys, which is an aggressive government-driven program. So my take on HPV vaccine, definitely for every girl between 9 to 15, it should not be discussed, or it should not come to the point of discussion between an oncologist or a gynecologist or a gynecologist as well. It should finish off at the level of pediatricians only. And at the community level, at the PHC level, at Asha worker level, at Anganwadi level, where everyone is being vaccinated, it should finish at that level only. It should not need to be discussed at this level at all.
Right. So 2 weeks back, on 29 November 2025, the Cochrane Network meta-analysis was made. So effect of HPV vaccination program on community rates of HPV-related disease and harms of vaccination. So reduces the incidence of cervical cancer by around 80% in people vaccinated at or before the 16 years. Reduces the incidence of high-grade cervical precancerous lesions as well as anogenital warts. It is not associated with increased risk of long-term side effects or infertility. It is more effective when given at or before the 16 years, before onset of sexual activity. And reduces frequency of vaccination targeted HPV types, genital warts, herd effects, reduce cytological abnormalities and referral to colposcopy, reduce frequency of CIN2 and CN3, and reduction in cervical cancers just emerging. So more than 300 million doses administered, no deaths have been linked with vaccination, side effects similar to other vaccines, anaphylactic reactions 1 in 200,000 doses. So definitely a safer. So any successful program you are aware of? So in Bhutan, so where you can see, so as I showed in the initial slide, so they have been a 4-line example. So neighboring country, any screening program you are aware of in India? So somebody, so Dr. Praveen, so any screening program you are aware of in India? So
Sir, since I'm from the state of Tamil Nadu, the Lancet paper by Dr. Shankar Narayan is itself a huge success story in which they had screened using VIA technique in the district of Dindigul. Again, that was done in a tier 2 district because the registry there is very strong. So it again added to a lot of incidences and being reported in the registries. And I believe that is a really good example of a success story, and that has like you quoted before, it has resulted in 25% reduction in the incidence as well as 30% reduction in the mortality of cervical cancer.
Absolutely. So great. So this can be a leading example for Punjab, Sikkim, Delhi, and Tamil Nadu has been the forerunner. So these are in the news. The Hindus, Tamil Nadu to launch HPV vaccine program in the 4 district with high risk of cervical cancer. Tamil Nadu becomes India's first state to offer free cervical cancer vaccines. So these are all the news in this week only. And has HPV vaccine received a push in budget 2024 last year. And again, Pune Jila Parishad partners with Serum Institute of India, Jivika Foundation to roll out in January 2026. So your take on vaccines from MNCs, so which are there and the made in India. So Dr. Praveen, and any experience?
So I believe the Serum Institute's vaccine, the Servavac, comprehensively covers the quadrivalent strain in which 6, 11, 16, and 18 all the strains are covered. And while the recent NEJM paper reported non-inferiority of a bivalent or a monovalent vaccine, I believe the same can be extrapolated and be applied for safely for the quadrivalent as well.
Absolutely.
And
So the cost
yes,
is also low, but again,
yes.
so unfortunately, the coverage remains extremely low, only about 1.3%, what Dr. Mayur said, according to the recent surveys. So otherwise, so it is good to go. So you can left and right prescribe the Indian vaccines from the Serum Institute. And this has come after the Make in India program, after the COVID vaccination got launched. So your take on post-vaccination scenario, any country do you think, though Dr. Mayur said Sweden, do you think on this war path already? So Ashish.
So sorry, sir, what was the question?
So question is that your take on the post-vaccination scenario. Now you see, so the year 2030, so we are done with the targets. So what will be the scenario like? And any country do you think on this war path already? So Dr. Mayur rightly said Sweden. So any other country you know?
No, so I think Bhutan is doing really well, and few other countries near, even I think Thailand, Sri Lanka, they are also doing pretty well as compared to what we do. If somehow we achieve, hopefully we'll be achieving 90, 70, 90 strategy, then definitely we can reduce the burden of cervical cancer to such an extent that it will no longer remain a major health burden. That is what we all want, sir.
Right. As HPV vaccination coverage improves, HPV infection and CI becomes a rarer. Cytology and VI will be challenging in a low prevalence scenario. Less frequent screening will be the norm. Screening may be initiated later in the life, around 35 years. HPV testing is most suitable screening test in the post HPV vaccination era. And you also said, so screening may be done at a prolonged intervals, 10 or more years. So Australia, potentially the first country to eliminate cervical cancer. So fiction or reality. So this has been in the news by 2028. And so the final thoughts. So we are already on time. So where are we? So we discussed a lot. People still shy away from these symptoms. I have in my practice in recent times, 3 gynecologists dying of a cervical cancer. And these 3 gynecologists were heavy practitioners, renowned, but shy away from the symptoms. So, and nothing worse can be an example for this. Screening modalities, what, when, and where. Screen and treat. Screen, diagnose, and treat. So screening, awareness, and prompt actions are the key. So cancer is a heavy word. It brings with it fear, unpredictability, and the looming reality of staggering hospital bills that can push families into a debt. For many Indians, a cancer diagnosis still feels like a sudden blow with little warning and even fewer options. So now people are looking at changing the cancer word into something probably a different word. So, but in 2025, many cancers, except a few, are preventable. Cervical cancer is one of them. The sad part is that very few knows that it is preventable. The HPV vaccine has proven to be the most effective way of preventing the disease. In November this year, 2 major studies confirmed that vaccines against human papillomavirus have been highly effective in preventing cervical cancer and the early cell changes that lead to it. But the coverage is still extremely low, even after the Indian vaccines that is available. Only less than 2% of eligible women are being screened. The government announced a national HPV program for girls in last year union budget. So prevention works only when people feel confident, informed, and empowered. The vaccine must be integrated into the national immunization program with clear age-based guidelines, so every adolescent girl, regardless of the background, receives it on time. Awareness campaigns must be culturally sensitive, addressing myths around fertility, safety, and cost, common reasons for hesitations. So collaboration is the key. What Dr. Mayur said, schools, community organizations, state health departments, and private healthcare partners must work together so that the vaccination becomes routine instead of an exception. So 3 simple steps to eliminate cervical cancer: screening, HPV vaccination, and treatment for the early disease. So the cancer miracle isn't a cure. So ultimately, it is all about cure is an erroneous target. Cancer prevented is better than a cancer cure. So I acknowledge my colleagues who helped me for the slides, Dr. Antara, Dr. Santosh, and Ranjan. And thank you. So we are moving into a new year. So Merry Christmas and Happy New Year. I once again thank my panelists, Dr. Mayur, Dr. Praveen, Dr. Ashish, and Chandrakant. So over to Dr. Uma for the conclusion. Thank you so much.
Thank you, sir.
Thank you, sir.
Yeah, thank you, Dr. Ghansham. I think it was a very interesting, fantastic panel discussion and such a wonderful inputs from all of the panelists. So thank you so much. I know it was a difficult topic, but I knew you could. And the team who has helped organize this event today. So thank you all, and hopefully we'll meet again with another topic in the future. Thank you so much.
Thank you.
Bye.
Thank you all.
Bye.
Thank you, Roshni. Thank you. Bye.
Thank you.
Thank
Good
you,
night.
sir. So as we conclude, I thank all our speakers, moderators, panelists, and particularly our Program Director and President of IAIO for joining us today. This concludes IAIO Expert Insights on Gynecologic Cancer. Have a pleasant evening. Thank you all.
Thank you. Good night.